Go later. I'm Kara. It's nice to meet you guys.
Hi, nice to meet
Nice to
you.
meet you too. I
Are
see
you
it.
guys are you oh hi. Are you guys fellows, attendings?
Fellows.
Fellows. Okay, great.
Hey, Kara.
Oh hi, how are you?
Good. How are you?
I'm doing well. Thank you
Thanks
for
so much
having me.
joining us. What's that?
Oh, thank you for having me.
Oh, of course. Yeah, excited to hear your presentation.
Great. How's my hometown of Ann Arbor?
It's great. It's beautiful and sunny. It's, when the town sells itself for sure. It's like football season. It's warm. It's sunny. It's back.
Yeah, I miss it. I was actually just back there, not last week, but the week before. It was,
Oh, cool.
yeah.
Nice. Nice. I imagine the weather must be similar in Rochester.
Yeah, it's actually been really beautiful here. September is like my favorite month, weather wise. So,
Awesome. Very cool. Hi, everyone. Thanks for meeting with the applicants today. Carol, we had an interview day today.
oh,
Earlier.
fun.
So,
Okay,
yes.
so are some of you applicants then?
No, they're all our fellows, but
Okay.
they're our ambassadors.
Oh, okay.
Yeah.
That's fun. Exciting times.
Yes, indeed.
Right. Well, let me pull up my slides and
Yeah, make sure that you're able to share.
I'm ready whenever you guys are.
Okay, just give it one more minute or so for people to join in, and then I'll go ahead and get started.
Oh yeah, it's exactly noon, so we don't need to be that prompt.
Well, it's just as people, just to make sure everyone gets a chance to log in.
Eric Olson said he had a meeting in Ann Arbor not too long ago.
Yeah, in the summertime board
Okay.
meeting. Yeah. So he was here. And we were texting about something else and he actually said go blue. And I was like, Eric, are you okay?
Yeah. It's really funny. No, he told me he'd never been to Ann Arbor before. And I was like, oh, so he said
Yeah.
it was nice.
He's so funny, but he's such a staunch Notre Dame fan.
Oh, really? Oh, okay.
Yeah.
I just didn't know that. I don't know anything about
When
sports.
he
I have to
dropped a
admit.
go blue, I was like, all right.
I did my undergrad at University of Michigan, and I did not attend one single football game.
Oh, well, you'll have to rectify that at some point.
I don't know about that. I like soccer. I'll watch that.
Oh, there you go. Soccer teams are fun to watch here too. Great.
Yeah. I just don't understand football, and it's like too much. Everyone says soccer is boring, but it's like football. They play for 10 seconds and then they stop. It's very, I don't know. It's just like continuity, I guess.
Fair enough. Clock keeps running on soccer.
Yeah. Oh, that's the other great thing about soccer is that they are 90 minutes and then the game
Yes.
is over for the most part, you know. You're not going to be sitting there for 4 hours.
Also true. Also true. Yes. Well, it looks like people are joining in, so we can go ahead and get started. So good afternoon, everybody. I'm excited to introduce Dr. Kara Dupuy-Macaulay to our grand rounds today. She's an assistant professor of medicine at Mayo College of Medicine. As you may have heard her say, she's a Wolverine, and she actually studied music and technology and piano performance here at Michigan before making her way to Wayne State for medical school and serving as an academic chief resident at Beaumont Hospital, followed by fellowships in pulmonary diseases and also in sleep medicine at the Mayo Clinic, where she's currently a faculty member. Her focus areas are central sleep apnea and hypopnea classification, obesity and respiratory health, behavioral interventions in sleep medicine, and sleep-related care in distinct populations. She has been noted by the American College of Physicians to be a rising star and has received their Distinguished Chest Educator Award and also recently Teacher of the Year by Mayo Fellows Association in the Department of Internal Medicine and Sleep Medicine. So welcome. We're excited to have you back in Ann Arbor virtually and excited to learn from you about central sleep apnea.
Thank you so much for having me. I only wish I could be there in person because I see a lot of people that I've met before in this call, and it's really nice to see you guys here. So, yeah, so thanks for having me and allowing me to talk about one of my favorite topics, central sleep apnea. Um, so this is one of the, oh, well, first of all, can everyone see my screen okay?
Yes, we can.
Okay, perfect. Yeah, so this is one of those things, it's kind of a confusing subject at first. And so and it's also an area of the field that has a lot going on. So there's still a lot to be discovered, you know, from a diagnostic perspective, from a treatment perspective. That's one of the reasons that I think it's so exciting. It can also be very frustrating because there's a lot of information that we don't have. But the purpose of this talk is, you know, I'm going to talk a little bit about the pathophysiology because I think that's important to, you know, build some of that foundation. But I'm also going to go over some of the new things that are going on in the field, you know, some of the challenges that we're facing right now, and you know, some of the places that I think that we need to go as far as research and treatment and things are concerned. So I think this is a really exciting field, and it's an exciting time for this particular disorder. So I hope that you enjoy it. All right, so as we all probably know, central sleep apnea is when you see an episode of apnea on a sleep study and there is reduced or absent airflow along with reduced or absent effort. However, central sleep apnea is not one thing, and this is where part of the problem lies. So central sleep apnea is a group of disorders. You can have primary or secondary sleep apnea. Sometimes we call primary central sleep apnea idiopathic. And then secondary can be broken down into several different categories. So Cheyne-Stokes respiration, commonly seen in patients with heart failure, high altitude periodic breathing, treatment emergent central sleep apnea or central sleep apnea due to medication. And then these can be further classified by their pathophysiology. So there's high loop gain. I'm going to explain a little bit more about this in a second, but the types of central sleep apnea that are thought to be related to high loop gain are primary or idiopathic, Cheyne-Stokes respiration, high altitude periodic breathing, and treatment emergent central sleep apnea. We also have central sleep apnea that can occur due to failure of rhythmogenesis, where the brain just is not sending a breathing signal because it is somehow affected physically in the area where the breathing rhythm is created. So this can potentially be due to medications. The most common one would be opioids, but there are different medications that can cause central sleep apnea. And then you can also have a structural lesion. So if you have a Chiari malformation or a stroke in that area or some sort of mass pressing on that area, then the center of the breathing rhythm can get disrupted. And then there's a category of other, which is central sleep apnea due to a medical disorder, but not Cheyne-Stokes. Beyond that, we have high loop gain with high plant gain, and this can happen in conditions with chronic hypercapnia and sometimes in spinal cord injury, and then pseudo-central sleep apnea. And this is a little bit different than other kinds of sleep apnea because the brain actually is sending the signal to breathe. It's just that the nerves or muscles or the thoracic cage is somehow impaired to the point where the signal to breathe cannot be carried out. So the pathophysiology is quite different with that one. All right, so first of all, high loop gain. This is a term that comes from the electronics world, and it basically is describing how different inputs to a system might affect the output. In this situation, the output is, you know, pH of the blood, homeostasis, and the various inputs into the system are the peripheral and central chemoreceptors, the blood circulation time or the mixing time, and then the lungs. So these can be influenced or influence this loop gain in a couple different ways. Part of it is from, you know, mechanical influence with the stretch receptors, and then part of it too is it has to do with carbon dioxide and change in carbon dioxide for change in ventilation. Loop gain causes this type of a phenomenon essentially. So usually the patient will be susceptible to exaggerated responses to changes in the levels of oxygen and carbon dioxide you know, potentially just because that's how they are and they just have this intrinsic sensitivity to that. But what might happen is that, you know, here we are breathing along with normal respiration. There's some sort of stimulus, and then the body responds in a little bit of an exaggerated way. So you have some hyperpnea, and here's your carbon dioxide. And we can see that when you have this hyperpnea, the carbon dioxide might drop below the apneic threshold, and then that generates a breathing pause. And then typically, when you have this breathing pause, you know, whatever stimulus that caused that whole cycle to begin with will come back, and then you'll have another breathing pause and then another one. And this is part of the reason that in a lot of types of central sleep apnea, we'll see really high AHI, because once you get into this pattern, it's really hard to get out of it without some sort of interruption. And so if the person doesn't have this sensitivity to the changes in oxygen and carbon dioxide, this is what might happen with a breathing disturbance. So say your carbon dioxide is really far away from your apneic threshold, as opposed to what we saw in the previous example. You know, you might be breathing along normally, and then there's a respiratory stimulus that causes hyperpnea. And yeah, maybe there's a drop in your carbon dioxide, but because you're far away from your apneic threshold, you don't get into that pattern of having central breathing events. So that's just an example of how that might occur in certain patients. Failure of rhythmogenesis. There's an actual physical place in the brain where the breathing rhythm is created here in the ventrolateral medulla. And so unfortunately, this area has opioid receptors, which is not wonderful. But so if it has any medications that are binding there, that can disrupt the breathing rhythm. And then, of course, if there's any sort of, you know, mass effect or other disturbance in that area. And then this is an example of plant gain. So this is CO2. We typically are living at a flatter part of the CO2 curve. And so if you have an increase in ventilation, the CO2 will go down a little bit, but it's, you know, a less prominent change. Whereas if you're somebody who is living on this part of the CO2 curve, for a little bit of an increase in ventilation, you can really drop your CO2 quite a bit, and you know that might push things below the apneic threshold. So this is kind of what plant gain is. And then again, with pseudo central sleep apnea, the brain is sending the signal, but the signal cannot be carried out for whatever reason. And so we still see on a sleep study, you know, no breathing effort and no airflow, but again, it's a little bit different pathophysiology. So despite this being a whole group of disorders with many different pathophysiologies, we really don't have a lot of treatment options for central sleep apnea, especially when you compare it to obstructive sleep apnea. I always think of us not having very many therapies for obstructive sleep apnea, but I guess when you compare it to central sleep apnea, it's there's a little bit more options. So for central sleep apnea, we have positive airway pressure therapy. Typically, that's going to be CPAP sometimes or ASV, except sometimes with heart failure with reduced ejection fraction, but that is changing, as I will be discussing in a minute. And then we have phrenic nerve stimulation. Do you guys do Remedy implantations over there?
No.
Yeah, as of now, no, but something we've been discussing.
Okay. Yeah, so me and one of my mentors, Dr. Morgenthaler, have embarked on a journey of implanting people with Remedy phrenic nerve stimulator. So that's kind of our, fun new implantable device for central sleep apnea. And I'll talk a little bit more about that later too, especially if you guys haven't seen it. And then there's some pharmacological therapy and oxygen. These things are kind of, less tested and less proven, and oftentimes they will improve the central sleep apnea somewhat, but maybe won't be a, total cure depending on the mechanism of the sleep disorder breathing. So anyway, just not a whole lot of options there. And so these are the limitations that we have when it comes to diagnosing and treating central sleep apnea. It's not one thing, it's multiple disorders. There are multiple pathophysiologies. Treatment is not necessarily chosen or reimbursed for, because that's another problem that we have sometimes. We want to give a patient a therapy, but insurance won't pay for it. And so we're not really choosing treatment based on endotype. It's just, this patient has central sleep apnea, here's a treatment for that. The other thing is, a lot of people with obstructive sleep apnea, they don't have central sleep apnea at all. But if you look at patients with central sleep apnea, a lot of them have obstructive sleep apnea. And so in a lot of cases, you're kind of having to consider both of those disorders and what treatment you're providing. And most treatments that we have for central sleep apnea don't work for obstructive sleep apnea. So that makes things a little bit more complicated. The other thing is that we don't even know how to diagnose central sleep apnea very well. We have a lot of deficiencies, even with accurately classifying disordered breathing events. And so, right from the get-go, there's going to be challenges if you can't even diagnose things effectively. And then the other thing is that we know very little about clinical outcomes in general, particularly clinical outcomes in all of these different subsets of central sleep apnea. And so that's kind of a blind spot in our literature in general. The literature that we do have is mostly associated with heart failure. And while we don't really have a lot of direct clinical outcomes about central sleep apnea and the treatment of central sleep apnea and, morbidity, mortality, et cetera, we know a few things from research that's been done so far. So central sleep apnea has been associated with signs of increased sympathetic activity. There's some studies about increased catecholamines in the blood, and just from what we know about repetitive arousals from sleep, that does tend to increase sympathetic activity. And increased sympathetic activity is associated with a worse prognosis in patients with heart failure with reduced ejection fraction. We also know that people who have an increase in their ventilatory response to hypoxia and hypercapnia, which would describe people with high loop gain, we know that that confers a worse mortality risk in heart failure with reduced ejection fraction. And then we also know that hypoxic time is associated with increased mortality in heart failure with reduced ejection fraction in a dose-dependent manner. And not everyone with central sleep apnea has a lot of hypoxia, but if you do have a patient who has significant hypoxia, that is probably also not good for the heart. So, a lot of the reason that we treat central sleep apnea is because we're kind of inferring that because it causes all these things that we know are bad for people with heart failure, hopefully treating them, there would be some sort of a benefit, but the literature really isn't there, honestly, to tell us whether that is, a defined, what kind of a benefit there would be. So at this point, we have some goals that we're trying to achieve, I think, as a, group of sleep doctors. So correctly identify people with central sleep apnea, avoid delays in treatment because of misdiagnosis or insurance reimbursement. Make sure that we are providing the right therapy to the right patient. One of the reasons that that's so important now is because of implantables. And then we really need research on clinical outcomes because, as I just mentioned, there's just a lot that we don't know. And the little research that we do have is basically in patients with heart failure and, these other types of central sleep apnea. There's just no data at all. All right, so I have a question for all of you. I know we don't have a response system or anything, so I'll just let you guys think about your answer for a couple seconds and then I'll tell you what it is. So which of the following statements best describes the role of hypopneas in the diagnosis of central sleep apnea according to current consensus and guidelines? So number one, classifying hypopneas is not necessary because the ratio of obstructive apneas to central apneas should reflect the ratio of obstructive hypopneas to central hypopneas. Number two, hypopneas are included in the diagnosis of central sleep apnea, but only if they're associated with arousals, and their classification of central or obstructive is not clinically relevant. Three, while hypopnea classification is optional, classifying hypopneas as obstructive or central may result in a different diagnosis than classifying apneas alone. And then four, all hypopneas should be considered obstructive by default in the diagnosis of central sleep apnea. So I'll let you guys contemplate that for a couple seconds. And does anyone want to say what they think the answer is?
Three.
Okay, good job. That is the correct one. So again, part of the reason that this is so urgent right now is because of implantable devices. I don't know about you guys. Are you doing Inspire at university? Okay. So I've seen, unfortunately, more than one Inspire patient who we kind of find out after the fact really has central sleep apnea and not obstructive sleep apnea. And sometimes this is happening because the patient just has a ton of hypopneas, and if you're not really looking at the hypopneas in detail and going out of your way to classify them, it can be easy to miss that diagnosis. And we don't want to implant a device in a patient and have it not be useful. That is not good practice. So I think now more than ever, there's just higher stakes. And so it is kind of urgent that we get this figured out. Apneas are more straightforward. Sometimes they can be hard to identify too, but you can rely more on the respiratory effort than in hypopneas. So central apneas, there's agreed upon definition, 90% airflow reduction, lasts at least 10 seconds, and you don't see any effort in the thoracoabdominal bands. Hypopneas, on the other hand, are a little bit more challenging. So the definition of what a hypopnea even is has changed a lot since they were first discovered in the 70s. I actually have a history of hypopneas presentations, so there's a lot of background there. But anyway, so I think, throughout time, our field has had a little bit of trouble just agreeing what a hypopnea is and how it should be defined. The most recent recommendation from the AASM as far as how they should be scored is that it should be a 30% reduction in airflow using nasal pressure, PAP, or an alternative hypopnea sensor, which they don't really define what that might be. It has to last at least 10 seconds, and it is associated with a 3% oxygen desaturation from pre-event baseline or an arousal. So we refer to this as the 3% rule. The optional way of scoring hypopneas is what we commonly refer to as the 4% rule. So, same requirements with airflow, but has to be associated with a 4% desaturation, and there's no arousal criteria for that. And now the latest is that we have to put both the 3% and the 4% on our sleep studies. And it's a little bit complicated because some insurances will reimburse based on the 3% and some won't. Medicare and Medicaid only recognize the 4%, so it's, a little bit of controversy within that already. The AASM does have a proposed hypopnea classification method, which is based on visual cues. So they say that if you see flattening of the inspiratory portion of the nasal pressure transducer, snoring during the event, or thoracoabdominal paradox, any one of these three, the hypopnea should be classified as obstructive. And if it doesn't have any of these three features, then it should be classified as central. And the reason that this is important, we've all, it's not like hypopneas are this minority disordered breathing event that barely ever happens. They make up 60 to 80% of disordered breathing events. And we've all seen these patients who just have all hypopneas. And so, sometimes it's really hard to tell what kind of disordered breathing they have, or, what proportion of obstructive to central events they have when there's so many hypopneas. There was a recent study actually that looked at over 4,000 PSGs, and 55% had moderate to severe sleep apnea. And when they classified the hypopneas, they found that the diagnosis of central sleep apnea was 4 times higher. So it went from 5% to 20% when they were diagnosing hypopneas versus when they didn't diagnose the hypopneas. So this would seem to suggest that we're missing a lot of people with central sleep apnea by not looking at the hypopneas. In the past, there has also been a bit of a practice of just assuming all the hypopneas are obstructive. I mean, that's kind of what we do with our home sleep apnea tests, we did a paper looking at patients who had been implanted with Remedy and just scoring the hypopneas that were present in their sleep studies before implantation and after implantation. I'm actually just uploading this today, so hopefully it will be published soon. But we discovered too, similar to that other paper that I showed you, that if we had, just kind of disregarded the hypopneas or assumed that they were all obstructive, then only 63% of these people would have had more than 50% of their baseline events considered central. And if you look at the central apnea index, or central apnea hypopnea index, 95% of people met criteria versus if you only look at the apneas, only 73% met criteria for diagnosis for remedy implantation. So anyway, there was a 30% difference in the percentage of central apneas versus the percentage of central hypopneas. So there were generally more central hypopneas compared to obstructive hypopneas than central apneas compared to obstructive apneas. So anyway, this is all to say that you can't necessarily rely on the ratio of central to obstructive apneas to tell if your patient has central sleep apnea or obstructive sleep apnea. Classifying the hypopneas can really change that in a significant way. So one of my projects when I was a fellow was assessing the accuracy of these visual methods to see if this is, something that is valid to use. So we took the AASM criteria, which is listed in black here, and then Winfried Randrath, who is a researcher who does a lot of work in this space, he proposed adding these other features to that visual criteria to see if it was any more accurate. And so that was sharp termination of the event, arousal right when the ventilation resumes, and the event occurs during stage REM sleep. So these would all be more suggestive of an obstructive hypopnea rather than a central hypopnea. And what we did is we basically compared the AASM algorithm to the Randrath algorithm. We applied it to a set of 100 hypopneas, and we had a bunch of different people of all different levels of training score them. And we found that the accuracy was actually about the same between the AASM method and the Randrath method, with very similar sensitivity and specificity. And the accuracy was okay, but the real problem with this was that the inter-rater reliability was horrible. So it just, when you looked at how one person scored a hypopnea versus how another person might score a hypopnea, there was really no consistency. And so I think that was kind of the main limitation here. The accuracy of 70%, that's okay. But the inter-rater reliability, man, that was a huge problem. So what we basically concluded with this paper is that, probably neither of these methods is really sufficient to give us an accurate hypopnea classification. And more recently, there was a paper that I really like. If you guys haven't read this, I would really recommend it, by Javaheri, Rappaport, and Schwartz. And they proposed a bunch of different features that you can look at for diagnosing obstructive versus central hypopneas. And the two studies that I mentioned previously, the one from Pepin that looked at the over 4,000 studies, and the one that we did looking at the remedy cohort, that was done with this method actually, which has not been validated yet. So that is a major limitation. But that's actually my next project, is to see if this method gets us any closer to a reliable hypopnea definition than the previous ones. So on the obstructive side, is it worse in REM? Is there snoring? Is there thoracoabdominal paradox? Is there an abrupt resumption of ventilation at the termination of arousal? That would imply that, the airway kind of all of a sudden opens and the breathing starts again. Is there airflow limitation or prolonged inspiratory duty cycles? So when we see a prolonged inspiratory portion, that can sometimes indicate, a very narrow airway, and it just takes a longer time to draw air through that narrow airway than it would if the airway was wide open. And then on the central side, we have frequent central apneas, although, like I said, we should not be solely relying on the apneas to tell us if the overall disordered breathing diagnosis is obstructive or central. If there's this kind of waxing and waning, crescendo, decrescendo breathing pattern that we might see in Cheyne-Stokes respiration, if there's gradual event termination, that might suggest, rather than the airway opening suddenly, the patient is, kind of gradually coming out of the event. If there's a delayed arousal that occurs at the peak of hyperpnea, that's much more characteristic of a central event rather than an obstructive event. If there's a delayed zenith of the oxygen, that usually suggests that the circulation time is prolonged, and that's part of the pathophysiology of high loop gain. That's the increased mixing time. And so that might be a sign of central apnea, central hypopnea as well. All right, so those are the dilemmas in diagnosis right now. Like I said, we really don't have a reliable method of diagnosing central hypopneas. I personally believe that it's worth investing in a visual classification because it's using tools that we already have. There have been several papers over the years looking at various things like machine learning algorithms, chest wall EMG, and some other methods to detect central hypopneas. And some of them are actually pretty accurate, but the problem is that they require equipment that we don't already have in the sleep lab, and none of them has been widely adopted at this point. So, the easiest thing would just be if we can derive this information from the PSG signals that we already have. All right, so moving on to treatment. Which of the following statements best reflects policies from the AASM clinical practice guideline on CSA treatment? So this actually hasn't even been officially published yet, I don't think. So it's brand new. So is it number one, ASV should be avoided in patients with heart failure with reduced ejection fraction and predominant CSA due to increased mortality risk? 2, CPAP is first-line therapy and has demonstrated a mortality benefit in heart failure with reduced ejection fraction and CSA. 3, in high altitude periodic breathing, CPAP is the first line, but supplemental oxygen and acetazolamide may also be considered. And 4, bilevel PAP therapy without a backup rate should not be utilized for treatment of CSA in patients with high loop gain. Does anyone want to venture a guess as to what this answer is?
Either 1 or 4.
Okay, so this one is a trick question. The new guidelines are actually talking about ASV in a little bit different way than we have before. So we had the SERVE-HF trial that showed increased mortality risk in patients who were on ASV and had heart failure with reduced ejection fraction. But since then, we've had a little bit more research. I don't know if you guys heard of the ADVENT-HF trial. It kind of ended up being a disaster because of outside forces, but they were basically, looking at this issue again because the ASV devices that we use now have different algorithm, and they kind of, there were some, deficiencies in the first research study. Not to say it was a bad study. There's always deficiency in research studies, but so some people are kind of questioning whether that outcome was really something that we needed to worry about. So they started looking at that again, and unfortunately, then the Philips device recall happened and they were using Philips devices in the study, and then COVID happened, and so it ended up that the study didn't get finished. They did have 6 months of data. They didn't, enreach their target enrollment in that time, so I think we have to, take the, just consider that when looking at the outcomes. But there weren't any concerns about increased mortality or anything in that cohort with that data. So I don't think that's, definitive in saying that there's no risk to ASV in this population, particularly because they were also using a device that doesn't exist now. But, it kind of, I think, opens us up to, discussion about whether this should be reconsidered, basically. This is another paper actually that you guys should read if you haven't already. It's Insights, Recommendations, and Research Priorities for Central Sleep Apnea. It basically convened an expert panel and kind of talked about some of these issues with diagnosis and treatment and research with respect to central sleep apnea. And they basically said that when we're thinking about therapy for central sleep apnea, we should definitely treat if we're trying to alleviate symptoms of sleep fragmentation, frequent awakenings, daytime sleepiness. So these people, it's really easy to make the justification to treat them. It's the patients who are asymptomatic that, it's like, do we really have to torture you with this PAP device or not? And so the other things that they said about therapy is that, the first step actually should be just optimizing whatever is causing the central sleep apnea before we, take that extra step. They did say that hypopneas need to be fully classified so that we can start to study clinical outcomes. And then they also apnea may be helpful based on treatment response, and airway mechanics and things like that to understand more about the underlying mechanisms of disease. So kind of working backwards and taking the patient's response to treatment to learn more about the underlying cause. There's also a technical expert panel that convened a few years ago, talking a little bit about insurance reimbursement for central sleep apnea. This is just the definition of central sleep apnea. But they basically proposed that, CMS make it a little bit easier to get people treatment for central sleep apnea. They advised that the policy should not refer to hypoventilation because that's actually something that you have to, document that they don't have signs of hypoventilation. But, in this setting, it doesn't really make sense. It's kind of like a separate issue. And then the other thing that they wanted is to allow CPAP to be a therapy for central sleep apnea when it's shown to be effective. So, it's hard to get CPAP for people with only central sleep apnea. Thankfully, most of them have some element of obstructive sleep apnea as well. But for people with pure central sleep apnea, usually that's not going to be covered by insurance. And then they also recommended allowing us to prescribe oxygen therapy for central sleep apnea if it's shown to be effective. That's also another dilemma, is that sometimes I've had people pay for oxygen actually out of pocket because it works really well and they have no qualifying diagnosis and their insurance won't pay for it. So that's another thing that hopefully, will be changed one day. And then the other thing is that they recommended that the CMS policy should allow any treatment with any effective E0471. So this is a bi-level device with a backup rate. Even if a patient is previously prescribed and using a less effective BiPAP device with a backup rate. So basically saying, if you're on an ASB and you need to switch to a BiPAP ST or something like that, that should be, allowed. And then they also were suggesting, when we're evaluating patients for improvement in their sleep disordered breathing, it should also include measures other than the AHI based on the discretion of the treating physician. So, that's another thing that sometimes we have to document, is that, they have this disorder, they've improved during the sleep study. And so this is kind of suggesting that, there are other measures of improvement other than the AHI. And this is what that algorithm might look like in a perfect world, where we're just able to prescribe the patient whatever therapy that they need without any sort of, extreme barriers to that. So just keep this visual in your thoughts and put it under your pillow or something like that. Dream about it. Hopefully one day that this will be a reality. All right, so the other thing that is new, and this is actually very, very new, like I said, I think that the paper has not been officially published yet, but it's available online, is the American Academy of Sleep Medicine Treatment of Central Sleep Apnea Clinical Practice Guideline. I bet Dr. Shelgakar knows more about this than I do, but anyway, they addressed a variety of therapies and recommendations for treating central sleep apnea. They recommended CPAP over no CPAP for a variety of kinds of central sleep apnea, BiPAP with a backup rate over no BiPAP for, again, a variety of kinds of central sleep apnea. They suggested against the use of BiPAP without a backup rate, because oftentimes that will, not help things or make them a little bit worse. So that was the reason why the one answer to the question was wrong. They suggest using ASV for a variety of types of central sleep apnea, including patients with heart failure. And their remarks on that, again, there's a person here who knows more about this than I am, so feel free to chime in if I'm, messing any of this up for you if you have anything else to add. But devices that deliver ASV have different algorithms for sensing and responding to events, and safety data is not available for all devices on the market. Increased mortality was associated with only one device in patients with heart failure with reduced ejection fraction, and this device is no longer being manufactured. So I don't take this as an enthusiastic recommendation, you know, use ASV for everybody, but I think it opens it up to the, you know, to the possibility that we might not see the increased mortality risk with the current devices. And I mean, I do sometimes talk to people with heart failure with reduced ejection fraction. Sometimes they don't want an implantable device. They're not really open to remedy. And, you know, ASV is the only thing that's going to work for them. And I've had people tell me, like, you know, I'm miserable. My sleep quality is horrible. My quality of life is terrible. I will take the theoretical increase in mortality if I am getting a good night's sleep. So, you know, so I'm feeling pretty good that this at least kind of opens up that conversation. Dr. Turbin.
Hi, I just a quick question. Did the guidelines suggest use of ASV as opposed to no treatment, or ASV? Did they say about oxygen? Because
Well, yeah, so I'll actually get to that in 1 second. So they didn't really say like ASV compared to you know, they didn't say like ASV versus oxygen or anything like that. Um,
or no treatment. Sometimes they just say against no treatment.
yeah, and I actually I think that was the language. I don't know if I just copied it here wrong. Anyway, I don't know.
It's okay. I was just wondering because, our neighbor at Wayne State, Dr. Botter, is
Yeah.
always telling us, we'll get just as far trying oxygen. So
Oh, just as far as with the ASV. Yeah, so I mean, I don't know what your clinical experience has been with oxygen. There are certain patients that I meet where you give them oxygen and it all just melts away. You know, so some people must have a hypoxic trigger that's, you know, setting off this cascade of central disordered breathing events. But the more common situation that I see is that, you know, it helps a little bit, but, you know, their AHI, you know, goes from 50 to 30, you know, so, and that's kind of what the literature suggests too. There's not a lot of studies about oxygen in central sleep apnea, but the few studies that have been done show really a wide range of response to oxygen therapy. And when you look at the medians, I don't remember the exact numbers, but you know, it probably on average cuts the level of central sleep apnea in half. So I think it's a very reasonable thing to try. And I have a lot of people who've responded really, really well to it, but for some people it doesn't help. But that's kind of the same thing with all therapies for central sleep apnea, really. And again, just stemming from this problem that this is not one disease and we're trying to treat it as one disease. And that's probably why we're seeing such a wide variation in response to therapy. So they did talk about oxygen and they suggested using low flow oxygen over no low flow oxygen in central sleep apnea due to heart failure. And then they also talked about high altitude periodic breathing. Oxygen actually is the gold standard therapy for high altitude periodic breathing because that is, you know, you would presume a hypoxic trigger, and that typically works very well in that setting. They suggested acetazolamide over no acetazolamide. The data on acetazolamide is kind of similar to oxygen therapy. You know, there's certain people it works really well and certain people who it works not at all. And, you know, most of, you know, on average, it's kind of, you know, it's going to reduce it a bit, but probably not get rid of it. And then something that was completely new is they did suggest using transvenous phrenic nerve stimulation over no transvenous phrenic nerve stimulation in central sleep apnea, in primary central sleep apnea and central sleep apnea due to heart failure who have failed other therapies, which I think is a good policy. Obviously, you want to go for the non-invasive therapies first, and if that fails, this is, you know, in our back pocket, similar to how we think about Inspire. You know, I think about this in a similar way. It's kind of a salvage therapy. I like people to try non-invasive methods first, and then, you know, but if that's not working and the feeling is that they really need treatment, you know, appropriate thing to consider in these populations. These were mostly the people who made up the study that got this device approved. So primary central sleep apnea, 60% of them had heart failure. And so this is kind of the population that was studied, which I think is why they chose those two etiologies specifically. So Central sleep apnea, again, it's a diverse group of disorders. It's not one thing. And we have a lot of ongoing challenges, not only in diagnosis, but also treatment and then research regarding clinical outcomes. So I'm happy to see that there are more, expert panels and guidelines and things like that being convened, because I think that the first step is kind of getting everybody on the same page and taking an assessment of, where are we at today and what do we need to do to take a step forward. So I'm happy that this is all happening. I do strongly feel that hypopneas are really important in the accuracy of the diagnosis. Again, particularly with the implantables. Every time I refer somebody for Inspire or Remedy, I actually score all of the hypopneas myself, because I only want to have myself to blame if it doesn't work. It's challenging, even though I've looked at hypopneas a lot and study them a lot. It still, in a lot of cases, is really challenging to determine if they're obstructive or central on a hypopnea by hypopnea basis. But I really believe in doing that, especially when, an implantation is at stake, so that we're not putting a device into a patient needlessly. So what we really need to do in the future is know more about the clinical consequences, especially in asymptomatic patients. Because like I said, if the patient's symptomatic, it's a relatively easy decision that they need to be treated. But what do you do with people who are asymptomatic and maybe don't have a lot of oxygen desaturation and sleep disruption, but they have an AHI of 50, do we need to treat them or not? And the answer right now is, nobody has any idea really. And then, hopefully we're going to be working on more precise methods for classifying central unobstructive events in general. And then also, endophenotyping people with central sleep apnea and treating it more as a group of disorders rather than, one disorder. And then, studying combination therapies. A lot of patients, like I said before, have central and obstructive sleep apnea. And there's a couple of random papers about, using transvenous phrenic nerve stimulation in patients who have OSA and using it concomitantly with an oral appliance or CPAP in a low pressure setting. But we need more information about that. And more data on the use of supplemental oxygen in more trials comparing therapies to each other. Because that's another thing that is really lacking in this space too, is seeing, is this therapy more effective than another one? And these are, again, insights that are taken from that paper that I mentioned with the expert panel. So it's a really good paper if you are interested. The research that's going on right now, there are a few studies that I think are pretty significant. So, and Dr. Batter is doing I think the second one that I listed, I can't remember if it's the first or the second one, but anyway, some of this work is being done in Michigan. And I don't know if you guys are participating in any of these studies either, but there's a trial about using acetazolamide for opioid-induced central sleep apnea. We really have no data on that. Using positive airway pressure therapy plus Ambien and or acetazolamide, supplemental oxygen, and buspirone. These are things that we all need more information on. There's the REST trial, looking at longer-term outcomes of patients who were implanted with the Remedy phrenic nerve stimulation system. That has closed enrollment, but we're trying to figure out. We know that the phrenic nerve stimulation system reduces the AHI, but are there any other benefits as far as cardiovascular function, hospitalizations, mortality, and things like that? And then there's another trial through Afnimed looking at cifepixant, which is a medication that I don't think is approved in the US and I was not familiar with, but I think it's used for pain. And then acetazolamide in patients with heart failure or atrial fibrillation. And we are participating in that study. So, hopefully we're going to have more information soon, but, as of now, those are the limitations. But like I said, that's one of the reasons I think this is kind of an exciting time in this field. And I like treating patients with central sleep apnea.
Great. Thank you. That was fantastic. We'll open it up for questions while people are getting online. Oh, go ahead, Brad.
Hi, thank you so much for your presentation. My question is about when you score central hypopneas. For me, it's easy to see the snoring and the paradoxical breathing, but do you have any guidance on like the airflow limitation? Like sometimes I'm like, is it or is it not? Or do you have like a, how do you determine that?
Yeah, so I actually have a presentation with a few hypopneas in it. If you give me 1 second, I was a little bit concerned about having enough time. So but I might be able to find it really quick and I can kind of walk you through okay, yeah, here it is right now actually. So I do have an example of an obstructive hypopnea and a central hypopnea that I think illustrates some of these concepts. Um, oh, sorry, give me 1 second here. Okay, great. Let me share my screen again. Okay, can you guys see this? All right, so this is an example of what I personally think is an obstructive hypopnea. So, and the reason that I think that is that, so I don't know how your PSGs are configured, but for us, the nasal pressure transducer, the downward deflection is inspiration. So it's a little different than other places, as with many things at Mayo. But so this is the inspiratory portion. Can you see my cursor here? Okay. So this is the inspiratory portion here on the bottom. And you can see that as the event progresses, this inspiratory portion is getting flatter and flatter, and the time spent in inspiration is getting longer and longer. And so that would suggest progressive narrowing of the airway. So that's one reason that I would, consider this to be obstructive. Another thing is that, here's the arousal, and that occurs right here at the termination of the event. And you can see there's a huge inspiration, which makes sense because in an obstructive apnea, it's really the arousal that's bringing tone back to the airway and awakening the patient. And so when you see that abrupt event termination, again, that's more consistent with an obstructive event here. So this is occurring during stage N2 sleep. The REM non-REM thing, obviously is, not going to completely tell you if an event is obstructive or central. But so these are some of the features though that I consider when I'm scoring hypopneas. The other thing that I like to look at is the motion of the respiratory bands. There's not really any paradox here. You see persistent effort throughout the event, but that can be present in a central event too. And that's why it's so hard with hypopneas is that there is respiratory effort. So, but one thing that we can see in an obstructive event, it's not present here, but sometimes you'll see, persistent respiratory effort or even increased respiratory effort, whereas the airflow is decreased. That's also very suggestive of an obstructive event because the, person's working harder and harder to breathe, through a narrow airway, you're getting less and less airflow. Whereas, in a central event, you might expect a proportional reduction in airflow to respiratory effort. Xingang, oh, my friend, our former fellow. Do you have I see a few people have questions. You guys can ask questions if you'd like.
Yeah, I think we'll go with Mark, then Punita, then Jinhan. Thanks.
Kara, really excellent talk. One of the questions that I had, just curious for your experience in our collective experience, is how much night-to-night variability there might be in some of the patients that we see with central sleep apnea, and how much that might potentially could that lead somebody to getting maybe remedy that maybe shouldn't, or possibly prevent Inspire. So a case that I had recently, somebody was, it was a baseline study in a patient where Inspire was being considered. It was a patient of one of our physician assistants on the call. And we did score the hypopneas as central and obstructive. And there were a high amount of central vents on the study. It was maybe 50%, but clearly the patient had OSA.
Mm-hmm.
And on the patient's questionnaire, we give a post-sleep study questionnaire after the testing. The patient indicated that they slept much worse, and the sleep was very fragmented. And I guess that's one area that I've seen in my experience. Sometimes that first titration. Somebody maybe doesn't sleep as well. They might get more physiologic central events, more arousals. And how do we need to think about, I guess sometimes when I see OSA, I'm pretty confident I'm going to see it again. But I guess in some central sleep apnea, if there's a lot of Cheyne Stokes breathing, it's just very clear that they'll probably have this again, or somebody on opioids with a whole lot. But there seems to be, for me, a bit of a gray zone, especially maybe with the patients with OSA and CSA. If I look on a different night, how much would I see, and how might that affect treatment if we're only basing it on one night study in the lab?
Yes, no, that is something I think about a lot. So, you know, in the answer is, you know, it varies depending on the cause of the central sleep apnea. You know, and this applies more to the, you know, idiopathic central sleep apnea and central sleep apnea due to heart failure, or, you know, valvular disease or AFib, or, you know, things like that. That's why the most important thing to do is to optimize whatever underlying thing may be causing the central sleep apnea, because we have a sleep hospital service here, and one of the most common consults that we get is, you know, patient has heart failure and they're fluid overloaded, and, you know, they get an overnight oximetry for whatever reason, and it shows severe sleep apnea. And our advice is usually to diurese them, and it's just amazing how the central apnea will just melt away with a few days of diuresis. So that population in particular, I always tell them that, you know, we might need to make some adjustments to your therapy over time, because it can really be a moving target dependent on, you know, how good their valves are working, how well their heart is squeezing, how much fluid that they have in their body. So yeah, that population, I think you need to be really careful with what you do, and you really need to make sure that they are optimized as much as you can possibly optimize them before really making you know, a judgment on how severe their sleep apnea is, or whether they even have it or not. The other thing too that you mentioned is this, you know, there is a phenotype of person who, you know, probably, you know, has some sort of, you know, maybe a little bit of a tendency toward exaggerated response to changes in oxygen and carbon dioxide, or, you know, has some sort of tendency toward central breathing events, but they don't really have central sleep apnea. And that's what you described. Is you'll see patients who have, you know, they might have a lot of sleep-wake transitions, and they have a physiologic central after every single one of them. Or I've seen a couple patients too who kind of, you know, they'll fall asleep and they'll have a few central events, and then they get into stable sleep and they're okay. And then I've also seen people too who kind of have that situation, but the reason they have central sleep apnea is because they have an obstructive event, and then they wake up, and then they fall back asleep and have a central event, and then they have a couple more central events, and then they have an obstructive event, you know. So you have to be really careful of that too, because there are a lot of people who look like they have central apnea if you just look at the AHI, and you know, they're, you know, just if you look at it surface level, but they, you know, do they really have a clinical disorder, or do they just kind of have a lot of physiologic centrals with arousal? So yeah, I'm always on high alert for that type of situation. And that's why you just kind of need to be really familiar with these nuances if you're going to be, you know, assessing this patient population, and particularly for implantable devices. But yeah, and that's another thing we need, you know, more you know, literature about the different kinds of central sleep apnea. There are just so many different, you know, flavors, if you will. And, you know, in patients like that, I actually had a guy come to me with that exact situation. He wanted remedy, and he was diagnosed with severe central sleep apnea. And he was like, you know, I tried Ambien and it actually works really, really well. And so we actually did 2 sleep studies on him, one with Ambien and one without Ambien. The one with Ambien, his AHI, like he didn't even have sleep apnea at all. His AHI was like 3. And without Ambien, you know, tons of sleep-wake transitions, very, very disrupted sleep, lots of physiologic centrals. And so I was like, you don't need remedy, you just need more stable sleep. So yeah, that's an excellent point, and you do have to be really careful about that.
Thank you. Punita?
Yeah, I have to commend you for saying that every patient who's going to get Inspire device or other stimulation therapies, that you will be looking at every sleep studies on hypopneas. I mean, I mean, nowadays it's so many patients are coming up with asking for the device, stimulation therapies. How do you choose in every patient? Because it's sleep studies are read by different physicians and we believe in their interpretation. And we do have the exclusion criteria for the Inspire device having, more than 5 as a central sleep apnea index. Do you specifically choose a patient based on just strictly the hypopneas, like if the sleep study report states the hypopnea index is significantly higher than the obstructive events, and that's how you keep looking for if these hypopneas are central versus obstructive events?
So we do things a little bit differently here. We have some luxuries that I know they don't necessarily have other places. So we read all of our own sleep studies. So we don't have like a doctor who's like reading all the sleep studies for the day. We see the patient, we order the sleep study, we read our own sleep study, we see the patient in follow-up. So most of the time, if I'm referring a patient for Inspire, it's a patient who I did the initial consult, I ordered their sleep study, I read their sleep study. And then in those cases, like I said, I do look at every single hypopnea and I score them myself and I calculate the percentage. So it's very, by the book. And I tend to, if there's any question about central apnea, I tend to, lean away from Inspire because, even hypopnea classification, as I mentioned, is not perfect. And so even in some cases where, I just am a little nervous about it, I won't send them for Inspire. So, yeah, so that is definitely something unique that we have here. But even if I see a patient who I didn't do the initial consult and I didn't read their sleep study, I have their sleep study pulled from the archive and I read it myself and I score every hypopnea and then I calculate a percentage because I just, like I said, I've seen too many patients who, I would like to think that we're pretty careful here, but there's a lot of patients who come to us and because their Inspire treatment is not going well, and then we, obtain their outside sleep study, and oh, guess what? It's all hypopneas, and this patient actually has central apnea. And so I really don't ever want to be responsible for that situation. So I just feel like I need to try my hardest for that not to be the case. But I know though, not everyone has that luxury though. Not everyone has the time to do that. People, their sleep studies are read in different ways. So I know it's not, I have a luxury.
Great, thank you. Shinhan.
Hi, Dr. Dupree. So nice to see you again.
Hi, good to see you.
Yeah, I have one quick clinical question. So based on experience, what's your approach on those persistent possible treatment emergent central sleep apnea that's reflected on the compliance report, where we see like possible high central events while patients doing fine clinically otherwise? Like, when would you consider an in-lab titration just to either, make the number looks good or clarify the nature of those events versus just kind of watchful waiting and keep monitoring? And if you do decide to keep monitoring, do you have like a cutoff of the central events number where you feel like you need to like intervene?
So the short answer to this question is that there's no right answer. There's no data to guide us. So you have to follow your heart. I kind of, I kind of have an unofficial rule that if it's less than 10, we're probably good. And if you look at the literature about the correlation of downloads to PSG, if they're less than 10, they should have, perhaps mild breakthrough apnea, but it shouldn't be too terrible. But the problem comes in when it's more, a little like if it's 15 and they're doing really well, in those cases, I kind of look at the patient, what else is going on with them. If they've got like, horrible heart failure and all these other things going on, then I might, strive to get that a little bit lower. Sometimes I'll even do an overnight oximetry just to see, is this a situation where we're just having very, tiny fluctuations, or are we having really significant oxygen desaturation? That can really sway me in one direction or another sometimes too. And also because the machines aren't always accurate. And I don't know, I found especially like if someone is, lying awake at night a lot or has really disrupted sleep, like we were talking about before, sometimes you do an oximetry and it really looks fine. So, yeah, there's really no guidance in the literature, what to do with that. And so I just take it on a case by case basis and kind of try and, figure in their clinical history and oxygen desaturation and things like that. But it's not perfect, and it's only my own opinion.
Makes sense. Thank you.
Excuse me. Thank you so much. Well, that was fantastic. I think we probably could keep you another hour asking our questions, but we
Yeah, I have a
appreciate your
schedule
time and
like that
expertise.
too, so
Yeah, well, thank you again.
yeah, thanks so much for having me. This is really nice. I always like talking about central sleep apnea. So yeah, and nice to see you all.
Yes, you too.
All right.
Thanks. Take
Bye-bye.
care. Bye-bye.